I'd like to formally welcome back Dr. Katherine Davies, back for session 2 on neurophysiology and functional anatomy. And Katherine, thank you for your warmth and generosity in agreeing to come back. And I've only had rave reviews of how you ran your first session. So I think it's a testament that everyone's back again for more, and I think we've got some new trainees as well. So today, Katherine is raising money for the Asylum Seeker Refugee Centre, who do such an amazing job supporting and empowering individuals based on compassion to create positive change. And these are all the values that I hope to espouse with this relationship that I'm developing here. So without further ado, Katherine, over to you.
Thank you so much for having me back, Stan. I've probably got a lot to live up to after Mason there as well. So I hope that this is helpful for everyone again. All right. So for those of you who weren't here last time, I'm going to make this very interactive. I want you guys to participate as much as possible, but remembering that this is a safe space, and if you don't know, just say pass, I don't know, but give it a crack and see what you can do, because I think that really helps to try and, stimulate your memory by actually forcing yourself to come up with the answers on the spot. So I'm going to ask all of you questions throughout this. So don't feel like I'm putting you on the spot. That's just what I'm going to do. But hopefully you'll feel pretty safe to give it a crack and answer some questions. And if any of you guys notice anything that I might have wrong or that you've read differently, please just jump in. Like, you guys are the ones sitting the exam. It's going to be fresher in your brain than it is in mine. So without further ado, I'm going to launch you guys into a bit of a quiz in a moment. So you might remember from last time we covered cerebral blood flow, including the factors determining cerebral blood flow and those altering it, control of ICP, and also CSF. So that's just a little bit of a reminder slide there. So what I'm going to do is we're going to review some graphs that we went through last time. I'm going to get all of you to draw them, and then I'm going to pick one of you for each to show me what you've got and take me through it. So, and I'm going to give you 45 seconds this time, because last time I gave you 30 seconds and it probably wasn't quite enough. So first up, everyone can draw me a graph of PaO2, PaCO2 on the x-axis versus cerebral blood flow on the y-axis. And I'll set my timer. That wasn't the actual timer, team. That was just me trying to set it. Get going. All right, that is the actual timer. So, great work, excellent. Full marks from me. Looks exactly the same as mine. Probably the only other thing that I would add on to your graph there is the tapering out of the CO2 at either end of that linear range, showing the maximum vasoconstriction and maximal vasodilation at the upper end. But you've got the inflection points perfectly. So kicking up there at a PaO2 of about 60 to 60 millimeters of mercury, and a normal range of 50 to 60 millimeters of mercury, 50 to 60 mils per minute per 100 grams of cerebral blood flow. So I just picked the 55 in the middle. Excellent. All right, everyone's up for another one. Can we go MAP versus cerebral blood flow and factors altering? So for factors altering, I want you to think about things that might shift the curve left and right, and things that might shift the curve up and down. All right, everyone, that's time. That's great. That's spot on. So that's exactly what I have, including the changes with Mac there. And then the other things you can add into your graph is if you want to say the differences with increasing and decreasing CMRO2, that's what shifts the curve up and down, and changes that will shift it left and right. Neonate goes left and hypertensive goes right. Excellent work. All right, next one. I'll give you 30 seconds for this one because this one's a bit easier. Temperature versus CMRO2. All right, that's time. So let's pretend that it looks like this. Perfect. And a normal value that you could put on there would be, so a normal temperature, say like 37 degrees, and a normal CMRO2 of 3.5 mils per minute per 100 grams. That's usually where I tried to put my normal value to draw my graph from. Excellent work. All right, I think there's 2 more of these. Intracranialelastance curve. I've kept this a bit sort of broader because it's too obvious if I tell you exactly what I want. So hopefully you guys remember. So compliance is a change in volume for unit change in pressure, and elastance is the opposite. So it's a change in pressure for a unit change in volume. So can you guys draw me a graph of intracranial elastance with that in mind? 45. All right, that's time. So perfect. That looks exactly like my graph. So I've got volume on the x-axis, as you said, pressure on the y-axis, with focal ischemia happening at 20 millimeters of mercury and global ischemia at about 50. So excellent work. All right, last one. The last one's a bit trickier. So I want you to draw me a graph that shows intracranial pressure on your x-axis, and on your y-axis, I want you to put CSF flow in mils per minute. All right, that's time. So my graph does look a little bit different. You've got the flat bit going in the right direction. I probably should have given you a bit more of a hint with there being a line for production and a line for reabsorption. So your production stays constant pretty much no matter what, above a cerebral perfusion pressure of 70 millimeters of mercury. But as your intracranial pressure rises, you have an increase in a reabsorption. So you have like more CSF being reabsorbed to therefore compensate for the increase in intracranial pressure. So I usually try to remember, so production's constant, that's at 0.35 mils per minute. And I find that easy to remember because like our CMRO2 is like 3.5 mils per minute per 100 grams. So it's that 3 and the 5 sort of go together a lot with intracranial stuff.
Sure.
And then the points where it sort of goes from 0 to starting being reabsorbed is about 7 millimeters of mercury, and then the crossover point's at 11. So I've just popped this in as a learning outcome because as you can see, it's very similar to the SAQ, but it's not quite the same. So this SAQ has discussed the determinants and control of spinal cord perfusion, whereas this is spinal cord perfusion pressure. So take note of what is exactly written, because if it's spinal cord perfusion, you need to include like resistance, like your Ohm's law equation. If it's perfusion pressure, it's just going to be like your MAP minus your spinal cord pressure. So you don't need to worry about all of the resistance things. So it's just sort of, this was a hint to me to sort of really read the question and underline the important words, because you don't want to be talking about things you don't need to. But learning outcomes like this one are like gold for examiners, because you can just write it down as an SAQ essentially. So if you come across ones like this that haven't been written up as an SAQ before, they were the sorts of questions that we would do in our study group to try and turn into a SAQ, because it could easily just be the next one that comes out of nowhere and everyone's shocked by it, kind of thing. All right, so let's talk about spinal cord perfusion. So, this is going to go to the next slide. There we go. Perfect. Excellent. And so that's your spinal cord perfusion. If you, spinal cord perfusion pressure, if you wanted to say what is your spinal cord perfusion in general, what would you have to divide that by? That's part of it. Sorry, I'm just asking one of those what am I thinking questions. Sorry, I just meant like divided by spinal by spinal.
Oh yeah. Yeah, thank you.
Very good. And you've already said the next bit as well. So our Postel's equation is the next thing that we can include in here as well. Last question, we've just spoken about it in terms of intracranial pressure, but is there another sort of concept that you might be able to apply to spinal cord perfusion and spinal cord perfusion pressure? Yeah, exactly. So your spinal canal is also enclosed by your vertebrae, which isn't going to expand if there's space. So perfect. So we can talk about the Monro-Kelly doctrine for our spinal cord perfusion as well. So suddenly it's not quite so scary, this SAQ that came out of nowhere in 2016 and everyone didn't answer it very well. All right, so as Beck has said, the things that we need to sort of answer this question with, our determinants of our spinal cord perfusion is going to be factors influencing our MAP, although that is auto-regulated. Factors, so the second part of our perfusion pressure, our spinal cord pressure, which is determined by our Monro-Kelly doctrine, and we can mention CBP there as well. And then we can talk about things influencing our spinal cord vascular resistance. So this is determined by the Hagen-Postel equation. And we can talk about things influencing radius, and particularly things influencing, which is the most important, and also things influencing viscosity. And as we know, length is relatively fixed. So you can mention it, but it's not something that we can alter. So what are the types of autoregulation that we have in this like spinal cord? So for autoregulation, I pop in those things under metabolic that you've just mentioned. So things like hydrogen ions, potassium, adenosine, lactate, that all cause vasodilation. And our myogenic, as you mentioned, so it's the same range, 50 to 150 millimeters of mercury. And then I actually put the oxygen, CO2, and while they are metabolites as well, and they do contribute to metabolic autoregulation, they're important physiological variables to mention separately, I think, particularly because they have that neat graph that we drew before, and very clear sort of relationship, whereas the other ones don't have a specific graph or anything like that. So I think they are important to mention separately. But excellent work, you got all of that. So next question, can you tell me about the arterial supply to the spinal cord? Perfect, that's spot on. So that's exactly what we've got in this diagram here. And there is exactly what you said. So we've got our anterior spinal artery, which supplies that large chunk on the anterior 2/3. And then you've got your two posterior spinal arteries, which supply a smaller segment, posterior 1/3. And we've got that segmental reinforcement. Do you know what the main, there's like a name for a major segmental reinforcing artery. Do you remember what it's called? Hopefully no one asks you that, but it's there if you want it. All right, excellent. And there's just that blood supply distribution that we were speaking about as well. So that anterior spinal artery is very important, supplies a lot of the spinal cord, and it's at high risk of ischemia, particularly in things like thoracic aortic aneurysm repair endovascularly. So that's one of the things that you can consent people about if you're doing a TBAR is spinal cord ischemia and paralysis, which is a very catastrophic complication. All right, to tell me about the venous drainage of the spinal cord. So there's, unlike the arteries, there's like twice as many veins. So you've got 3 anterior spinal and 3 posterior spinal veins that line the pia mater, and they drain to your epidural venous plexus, as you mentioned. Great work. Can you give me a definition of the blood-brain barrier? Spot on. That's perfect. That's really all that you need to say for a very basic definition. You can also add in, if you want, that it acts as a barrier for homeostasis and protection of the brain. Excellent. All right. So the structural features of the blood-brain barrier, you can say it's a dynamic and functional neurovascular unit in that it is changing and there's like lots of components to it, that's comprised predominantly of endothelium, astrocytes, pericytes, and extracellular matrix. Can you tell me where the functionally deficient areas are of the blood-brain barrier? So these are the places that the blood-brain barrier is functionally deficient. I don't think you'd ever be expected to know this, hopefully, but you've got your subcortical organ, you've got your OVLT, I'm not going to try and say the Latin there, you've got your neurohypophysis, your median eminence, area postrema, as you mentioned, which is our chemoreceptor trigger zone, or involved in that, and you've got your subcommissurial organ, your pineal gland. So that's, and they're all kind of there around the fourth ventricle kind of area. So can you tell me about the microanatomical features of the blood-brain barrier? Very good. So tight junctions between our endothelial cells, as you mentioned, we've got our negatively charged basement membrane, similar to in the kidneys. And you've also got your astrocyte foot processes. Is there anything else? This is sort of like extra bits. This is obviously the main bit, but is there anything else that you can think of that might involve like regulation of substances across the blood-brain barrier, for example? So we've got our transporters, like you mentioned, for iron, including our ion channels and our GLUT1, being our constitutive GLUT transporter in the brain. And enzymes are also important things. So we've got mayo and acetylcholinesterase, which are important because we don't want us circulating, essentially like neurotransmitters getting into the brain and causing havoc. Like if you're circulating noradrenaline gets into the brain, that's going to cause all kinds of troubles. So that's why there's mayo. All right, excellent. So if we talk about our physiological significance, because that was the question, we've got things that it's freely permeable to things that there's selective permeability and things that it's impermeable to. Can you tell me what sort of things fall into that freely permeable category? The main things is things like oxygen, carbon dioxide, and water, as you mentioned. And then things, for example, like propofol, for example, that's very highly lipid soluble, is also going to cross our blood, and volatiles, also going to cross our blood-brain barrier. Can you tell me about the selective permeability for electrolytes and macronutrients? Like what sort of things are selected, like fall into that category? Yeah, that's spot on basically. So it's not, as I think we mentioned last time, it's not like an ultrafiltrate, if you like. It's very selectively permeable to different electrolytes. So as you said, like the chloride concentration is higher, but things like your calcium and potassium are much lower than in your serum, in your plasma, sorry. Yeah, excellent. Next one we're going to talk about is briefly outlining the roles of the hypothalamus. So who can tell me the definition of the hypothalamus? You could say, so I've got a bit of an anatomical and also a functional definition here in the same one. So I said it's the anterior end of the diencephalon that lies in the hypothalamic sulcus, divided into multiple nuclei that have many important roles in homeostasis, which is exactly what you said. Excellent. So let's talk about the functional regions. This cowboy is going to make sense shortly. Here's our functional regions. We've got our anterior, medial, lateral, and posterior. First question I have for you is, what are the roles of the anterior hypothalamus? So we've got our production of ADH and oxytocin, as you said, and that's released by the posterior pituitary. It's also involved in control of your parasympathetic nervous system and in heat loss mechanisms, so like vasodilation and sweating. Very good. Medial hypothalamus. In general, exactly as you said, energy balance, sexual behavior, and satiety. So last question, how does it actually sort of inhibit appetite? What's it sensing and how is it doing that? It senses your blood glucose levels. And if they're high, it inhibits your appetite. So lateral hypothalamus, can you tell me what the lateral hypothalamus does? It's involved in emotions, defense reactions, and thirst and hunger. It's the main ones. And then our posterior, which we've sort of spoken about already. Can you tell me what the posterior hypothalamus does? Spot on, exactly. So we've got our controller, sympathetics, wakefulness, as Sarah said, and also controls the set point of body temperature, and it's our heat gain mechanisms, not our heat loss. So now the cowboy is going to make sense to you guys. Bear with me with my terrible drawing. So this was how I remembered it. One of my study mates, Dee, came up with this idea, and I sort of changed it into a little cartoon. So imagining it as a cowboy on a horse. So the cowboy is like whipping the horse into shape and getting him up and about. So he's sitting on the horse's back, so it's dorsal or posterior. So he's awake, he's up and about, he's sympathetically driven, and he's hot, he's gaining heat because he's getting excited. And our poor horse is tired because he's being whipped up by the cowboy. So he just wants to sleep. He's cold and he's sleepy, and he's like got his parasympathetics mostly working, and somehow you can work into the oxytocin ADH release as well. So I had the little baby horse down the bottom for the oxytocin. And then the way we remembered medial was like, if you think of your chakra, like with your yoga, it's like calm, your energy levels, they're in the midline. So, and it's also like satiety because you're calm, you're satiated, and sexual behavior because the same thing, like it's one of those sort of, I don't know, it all sort of worked together, we thought. And then our lateral, if you're sort of emotional and you're hangry, you're like acting out, you might be defensive, and sort of like acting out. So laterally, like maybe outwards acting out was how we remembered that. So I don't know if that helps you guys, but that's how I remembered it. It did come up in an MCQ actually, and I did know which part of it was from my little cowboy. So last one, we move on from the hypothalamus. We're going to talk briefly about sleep. So between me and I think Mason went over pain with you guys. So between the two of us, we pretty much covered everything in the neurophysiology section, which hopefully has been helpful. So we'll talk about the physiological effects of sleep, particularly on the brain and respiratory system. They're the main sort of areas that it affects, but it does affect all organ systems, which we'll touch on briefly. Can you give me a definition of sleep? That's great. I think that's pretty much exactly what I have. It's a state associated with loss of reactivity, surroundings, or unconsciousness for which one can be easily aroused by sensory stimulation. And if you want to add in something about where it's from or what it's caused by, you can say it's an act caused by an active inhibitory process generated from the raphe nuclei and reticular activating system in the lower half of the pons and medulla, which secretes serotonin. But this is the main bit, and I didn't remember the second part of that when I was studying. All right, so let's talk quickly about EEG characteristics. Can you just give me very quickly just like an overview of what happens as you go from awake to asleep with your EEG characteristics? I don't want waves or anything. I just want like a general feeling of what happens. But all of that was spot on. So you could say that when you're in that continuum, from awake to asleep, you go from a formation and EEG characteristics that are low voltage and high frequency and desynchronized to ones that are high voltage, low frequency and synchronized. So you sort of go from that really small wiggly waves to the big slow waves, basically. And this is exactly what Kerry has just spoken about. So with our EEG frequency bands, we've got our delta as our really slow wave. So in like deep sleep, it's less than 4 hertz. We've got our theta waves, which are 4 to 7, alpha 8 to 13, beta 13 to 40, and gamma of greater than 40. And if you are looking at your amplitude of your EEG, it's very like low amplitude. So that's microvolts. If you look at things like on your ECG, it's millivolts. So it's really, really tiny changes in voltage that we're looking at here. Can you define EEG for me? My definition is very similar. I say it's the summation of excitatory and inhibitory potentials by the cortical pyramidal cells in response to discharges by the thalamic nuclei, which is recorded at the surface of the head. Can you tell me, what is frequency? What's the definition of frequency? That's spot on. Would you say that it's cycles per second? Can you tell me what is the amplitude? Yeah, the height of the wave. Spot on. Great work. Excellent. All right. So now we're going to talk very quickly about the stages of sleep. So can you tell me what are the stages of sleep and how, or like what types of sleep are there and how often do they cycle through? Is exactly it. You cycle through several times a night, and if your person's really sleepy, the REM might be really, really short or even absent at the start, and then your REM sleep tends to get increasing in duration further through the night as the person becomes more rested, which is exactly what you said. Can you tell me how many hours of sleep does a typical adult have and what percentage of REM is it? And then tell me how that's different in the neonate and the elderly. I'd be very impressed if anyone gets 10 hours sleep a night. I think adults usually get 7 to 8 hours sleep a night. I think I'd like to get 10, but typically 7 to 8. And you're spot on there in terms of, so REM is about 15 to 25% and more if you're more rested. Neonate, as you said, total 18 hours. So you've got more cycles there, more REM, and elderly, total reduced duration, as you said, and our REM is also reduced. Excellent. And here's just a pictorial of that. Let's talk about the physiological changes. So CNS changes. Can you tell me about what changes with REM sleep in our CNS? Spot on, exactly. And do you know how much your CMRO2 increases by? Yeah, no worries. So it does increase by about 20% compared to awake. So that's why it's sometimes called paradoxical sleep, because you actually got increased brain activity. And as you said, your flow metabolism coupling means your cerebral blood flow also increases, which it can actually increase by up to 2 times, which is quite significant. And also important to note in REM sleep, that's when you have dreaming. And usually people are more difficult to arouse than in slow wave sleep, but people do tend to spontaneously wake from REM sleep in the morning. Christy, can you tell me what the physiological changes are for non-REM sleep? And as you mentioned, important things to note in stage 2 is your sleep spindles, your K complexes. And then non-REM 3, you're starting getting more theta and delta, those like slower wave patterns. And then, but delta's less than 50%. And then by the time you get to stage 4, delta's more than 50%. And you sort of end up with this synchronized pattern. Excellent. Can you tell me about the respiratory changes in REM sleep? Perfect, exactly. So I actually have a decreased tidal volume of about 25%, and maybe slightly increased respiratory rate, which means that overall your minute ventilation can actually increase. But you've got, but as you say, like reduced response to hypoxemia or hypercapnia, and that's your highest risk of OSA. is during that stage as well. Can you tell me what are the non-REM changes with respiratory? Beautiful. That's exactly right. And the other thing to note is you do actually get decreased minute ventilation. So you've got your reduced tidal volume, but your respiratory rate doesn't increase. So you have overall decreased minute ventilation, but that's great. And the OSA risk is less in non-REM sleep. Can you tell me what are the changes in non-REM and REM sleep in terms of the musculoskeletal system? Pretty good. So you've got very significantly decreased muscle tone in REM. It's actively inhibited. But as you might remember, so it's a rapid eye movement. So you also get irregular muscle contractions, which contributes to those rapid eye movements. You can also get teeth grinding in REM sleep from that as well. So that's very good. And as you said, with our non-REM, our muscle tone is decreased, but it's not sort of as actively inhibited as in our REM sleep. Very good. Can you talk me through the CVS changes, so cardiovascular changes in REM and non-REM sleep? Spot on, exactly. And how much does your blood pressure decrease by in non-REM sleep? Oh, good. It's 10 to 30% was the numbers that I had written down. So it's quite significant, really. All right. Can you tell me about the endocrine changes? Sorry, this one's a bit of a rough one. Great. So ACTH is the other one that increases in your REM sleep as well, which makes sense because it's all part of that axis, so it all increases. And as you said, so in non-REM, it's decrease in your ACTH and your cortisol, increasing your melatonin at the onset, as you said. The other things that increase is things like your growth hormone, your ADH, and the prolactin. So that's why I know people don't need to go up and go to the toilet in the middle of the night because you've got increased ADH, reabsorbing water, which is quite helpful. All right. Metabolic changes. This is the last one of these ones. You tell me, what are the metabolic changes with sleep in REM and non-REM sleep? So you've got increased metabolic rate in your REM sleep, decrease in your REM sleep, in your non-REM sleep, sorry, including a decrease in your temperature and also a decrease in your shivering threshold. Can you tell me how much your metabolic rate decreases by non-REM sleep? It's about 10%. Can you tell me how much your temperature decreases by? Trying to unmute myself, sorry. It's not quite that much. It's 0.5 degrees and it's lowest at 3 a.m. So very good, everyone. Excellent. All right, that's the last of that bit. But in the last sort of, I know I've gone over an hour now, so you guys are probably pretty keen to have a bit of a break. I've got a quick quiz for you guys at the end, so everyone can get involved here. It's very short, I promise. So can you give me a normal value for CMRO2? Perfect. Beautiful. And it's our 20% of our total body oxygen demand. What's a normal value for cerebral blood flow? Spot on. Beautiful. Can you tell me what is our normal rate of CSF production? Yeah, exactly. 500 mils a day or 3.5 mils per minute. Great work, everyone. Next question. what's the MAP autoregulation range? Great work. And last but not least at all, what percent decrease in CMRO2 do you get for each 1 degree decrease in temperature? Beautiful. Awesome. Great work, everyone. That's all I have for you. Any questions, comments, thoughts?
Katherine, I think the 500 mils a day works out to be 0.35 mils per minute instead of 3.5.
Oh, thank you. That's probably me.
Thanks so much, Katherine. That was amazing. I love the little quiz at the end. I think that that's a really fun way to learn. We'll need you to come back to do like something like Sale of the Century, but primary exam style. Oh, hey, Katherine, I've got one. So for the last question, which was the physiological changes in sleep, and it's more about sort of practical aspect and in terms of the layout of your answer. How would you lay out your answer? Would you draw a column right down the page, and then after that, put the different organs that are affected by it?
Yeah, I think that's what, when I did practice this question, that's how I did it. I found that a lot of questions in your head, it would lend itself really well to a table, but then in practice, when you actually get to the page is so small and you want to write all this stuff on it. But I think for that one, it actually does work quite well. So I'd have like non-REM and REM, and then I'd have like leave a whole page because you've got heaps of pages in the booklet. So I'd have a page for CNS, I'd have a page for RESP, and then I'd have a page for all the other ones because they don't take up as much space. But I think it does lend itself really well to a table.
Oh, great. And I think it's also interesting to ask you your writing speed and how many pages did you write for this exam?
My writing's very big, so I don't know that mine's necessarily an idea of how many you would expect to get out. If in an answer that had lots of graphs, I'd have maybe 4 pages, but I think most, or if I spaced it out a lot, but in reality, you don't really have time to write more than like 2 or 3, even though you've got like 10 pages in the booklet.
Mason was 76. I could not believe it. 76.
Oh, in total. Yeah. I mean, I don't know how many in total, but per question, that's probably what I got.
So
to.
that's averaging above, just a touch above 5.
That's about 45.
He was touching above 5 pages a question. That is a lot. But I think that's important to note because one of the things that I've been seeing as I've been marking answers is for trainees who can only write about 2 pages, and that's a physical limitation, which is very hard to improve. And I think that it's about sort of knowing what you're capable of, and you need to be strategic if you can only write 2 pages. So as you can see from what Katherine and Mason have said, they're averaging about 4 to 5 pages, which would tell you the amount of that's what they can write a lot more information out there. Because I know it gets frustrating at this point in time when you're getting your feedback from your answers and you're being told more breadth, more depth, and you're looking at what you've written and you're going, I've used up all my time. It's like, I'd love to have more breadth and depth, but if I can't write all of this in 10 minutes, then this is where you need to sort of understand that those limitations will mean that what you should aim for should be something a bit more realistic, which is probably around that 3 out of 5 mark. And I think getting a 3 out of 5 is still really good, because you think about this, you get 3 out of 5 for 10 questions, and you get a 2 out of 5 for another 5 questions, you're above 50%, which means that your pass rate is 95%.
Yeah, that was definitely what I was aiming for when I was practicing them. I was like, if I could get 3 on like as many questions as I can, then you can always go back and fill in stuff later. And I thought I would have time to go back and fill in questions, and I had 4 minutes at the end of the exam, and I had so many booklets that I wanted to add things to, and I just really didn't add anything to my answers in the end. I spent the whole time being like, oh my gosh, which booklet should I add this to? So I think like if you do have time left at the end, that's great, but you're not going to have enough to actually go through and add anything meaningful, was what I discovered. So just write what you can in the time. When the realistically when the 10 minutes is up, I tried to stick to like 9 minutes, so then I would have time at the end, but obviously that didn't quite work out. But yeah, just move on and you write down what you write down. And I think Mason had this really great style, which is probably like why he wrote so many pages, is his was really spaced out. So he'd have a big graph and a bit of information at the bottom, and then he'd like move to the next page. So it was really clear and easy to read. And he got a lot of information down, but despite using up a lot of pages, it was actually quite succinct. It wouldn't have been, it's not 6 to 7 pages of handwriting. It's like big graph, a bit of writing. And that sort of depends on the type of question as well, I guess, how much you're expecting to get out in terms of number of pages.
Yep. No, that's really, really helpful. And I think, you know, there is a bit of science to it. It's called mastering the time, space, and speed domain of answering a question. So the time aspect is your limitation. The space aspect is how you space out, how you lay out your answers. And then the final component is how much you can actually write in terms of words per second.